at Dawdle.live. We have with us Mukesh here, and Mukesh is the founder and CEO of Carely. And thank you so much for taking out time, Mukesh, to share insights on the product that you're building and the problems that you're solving. But before we start and jump into the product part and the business problems, we would like to understand from you a little bit about your professional journey so far and how did it lead to Carely?
I started my career in technology in 2000, where, just like any other person, I started my career developing software. And last 25 years, I have moved in the technology ladder. And I have, like every one of us, have this dream of coming to the, West and spending a little time, which was a choice for me. So 2012, when I moved to US, and since then been in the US in the technology, and last 1 decade has been in technology and healthcare, building healthcare technology for large enterprises. So been here, done that kind of, in this healthcare CRM work. So when COVID hit, all of us um, had one thing that was common in the war is, we started living for life, right? One thing that we realized is life has more value than the wealth, right? So that's exactly the time when I started ideating this concept of patient monitoring at a distance. So the idea was that how can I monitor my parents' health back home, right? Sitting in US, 13,000 kilometers far away, but is there something that I could do so that I can monitor how my parents are doing with their health? Even if a little bit of understanding how they're doing would help me. And that's how it started. So as with my co-founder, who's based out of Mumbai, Rasika Birewar, she has almost 25 years of healthcare consulting. We have pretty much similar thoughts, and that's where I met Rasika 2.5 years back. We aligned with our thoughts, and then we decided to start Carely, which is a patient monitoring platform. I'll talk more about that. And we are doing, I would say, we are pretty young as a startup, and we are okay as we start this journey and trying to disrupt in the healthcare remote patient monitoring space.
Thank you so much, Mukesh, for taking us through this journey. The first thing that we have for you is that what are the main features of the product? Like, what does it do?
Sure. So before going to the feature, one thing that I would rather call out is what problem that we are solving, right? So you can relate then with the feature. So primarily our focus is post-hospitalization care or recovery care, if you will. What the problem we see, and it's a global problem. It's not something that it's just in India or it's just in Southeast Asia. It's a common problem for patients that get discharged and go back home. They are almost on their own in the recovery journey. If you look at the hospital stay of a patient is on an average 3 to 5 days. However, the recovery process is from a week to months, right? And that is the phase where the patients, the caregiver, the family members, they need support, right? And they need support understanding what really is happening with them during the recovery process. When we look at the stats, right, mostly for specialty conditions, what we have seen is 28% population develop some complications post-discharge. So they came out of the hospital and they will develop some kind of complications. Out of that population, nearly 2.4% is the mortality rate, all right? Which is a large number if you look at, right? During the recovery process, it's quite a big number, 2.4%. And then the other thing, if you look at the readmission rate of after a post-hospitalization within the 30 to 90 days is closer to 10%, okay? So now what we came up with our solution, yes, we can't solve the, world's hunger problem, but what we thought is this is problem that can be addressed in terms of having a technology that can help support the patient, the caregiver, the family member, knowing what is happening during the recovery process, which is a very important part. And that is where what we did is developed a product. It's a digital technology driven product where we can monitor the patient at a distance and we can monitor their conditions, their vitals. We can create a medication adherence for them and do an end-to-end monitoring so that during the recovery process, we become their caregiver virtually. And then what we do is with this entire concept, as we design the product, the idea is that we work with the provider. Provider is on where, the patient is actually the provider's patient here, right? We are trying to bridge that gap between the provider and the patient by coming in the middle and helping both of them so that during the recovery process, the provider knows what really happening with the patient. Today, if you look at, there is no data that says that if a patient goes back with a cardiac condition, these percentage of population develops this kind of problem. We don't have that data today, right? As we start, piloting this product, what we have realized is post a cardiac surgery, there are many symptoms that are developed. And I'll give an example of our pilot. We ran a pilot with a stent manufacturing company for 7 to 8 hospitals in India for closer to 200 plus patients. Okay. And what we have learned out of that is post hospitalization at home, there are 50 plus symptoms that the patient has developed within the 250 cohort, right? Different conditions like the patient feeling breathlessness, to chest pain, to diarrhea, to fever, to a lot of that. That data is not there. All right. And that is where we help the patient in their journey of recovery with our technology, right? And then we try to bridge that uh, with the provider that provider can make a decision at the right time. Yes. So that's kind of what we are building as KFD.
So provider can make the decision at the right time. But will not providers say that, if they have problem, they will anyways come to me?
Yeah, great question out there. Let's look at India um, as Bharat, right? 70% of the population, I may be wrong saying that, but 70% of the population is rural population,
Yes.
right? We are talking about, a person getting operated in a hospital in Delhi, but the person has to travel 200 kilometers to come to
Yes.
Delhi, right? That's kind of the problem that we are trying to solve here, where, if we give this technology, we know really what is happening with the patients when he's at home. It will take him at least 5 hours to reach Delhi. But when we are monitoring this patient, and if there is an emergency situation that has occurred, we work with the provider and at least, okay, we can either shift the patient to the nearby hospital, or if it is something that the patient can be managed with the provider help and can be shifted to the provider next day, that can be done too, right? So think about, and this is from the pilot that we have done. I was talking about the 250 pilot. Today, we have around 1,500 patients that we have piloted this product. At least during the 250 pilot, we have seen 4 emergency cases. Okay? Where the patient were really transferred back to ICU or emergency room. Up to last week, I'm talking about last week, when the patient was in an emergency situation, we worked with the provider and this was like midnight, but the provider actually responded to us and asked the patient to come back to hospital in the emergency room. That's the power we are trying to create. Of course, the provider will anyway tell the patient to come back to the hospital. We also want that, when we are bridging this gap with the provider, we want the patient to come back to the same hospital where they were operated and to the same doctor that we're operating. And that's the bridge that we are creating. But there could be many conditions that can be managed at home with the provider's help. Or if there is an emergency, you don't need to wait to come to, 200 kilometer traveling and you can still be managed in a nearby hospital as well. And that's what we are trying to create.
So once you say providers help, do providers also send their nurses or doctors as per requirement to their homes?
And that is the difference we are creating here, is a case that we are not a company where we believe in physical model yet, because what we do is the similar thing that a nurse would do at home by understanding the patient condition. We are trying to do that through app or virtually, like you said.
Mm,
So with that, what we are trying to avoid is a physical visit of a nurse, which at a point doesn't scale. And with the limited resources in India or across the globe, which we know that there is lot of study that is happening on nurse burnout, if you will.
mm,
Now we are creating another layer on top of it to send a nurse to home. Instead, what we are trying to do is, hey, patient, if you have a feel something, just go to my app, chat with me. We will call you back. We run a command center 24/7. You can reach out to my call center. You can talk to me. I will understand. I have nurses at my command center. They will understand your problem. And also, one other thing that I would like to mention, both our apps and our command center is natively enabled with their language that they speak, which is a
mm,
key factor where, if you're comfortable speaking Hindi, then the patient engagement that we are doing in our app is through Hindi. If you are more, conversant with Marathi, then you can actually converse with us in Marathi, both in the app as well as in my command center. So that's kind of how we are creating it. And what helps out there is one that builds the relationship with the provider, where the earlier what was happening is the patient goes out of the hospital and there is no relationship between the patients and the hospitals, right? That relationship is broken. Now we are trying to bridge that relationship and saying that hospital, we are there for you, and patient, we are there for you. Okay. And then as needed, we will, come to you, provider, doctor, right, for this patient, who needs help, right? So that's what we are trying to do. And in overall, all of this, what they're getting is a real time data. So the way we do that is just like in a hospital setup, what happens, Rishikesh, and this is kind of everybody can relate this. When you are moved out of the ICU to a ward,
mm.
there is a certain routine that happens. One, every morning there will be a doctor rounds.
Yes.
The doctor will ask certain symptoms. Okay.
Mm,
He will ask how are you doing? Do you have a pain in your surgical area, or any oozing or any blood coming out? Da, 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 da. Or if you have any different disease conditions, different kind of symptoms that the doctor will ask the patient,
mm,
and then the nurse will come and do the vital check,
mm,
right? How is your blood pressure doing? How is your oxygen saturation doing? Or let's say if you're diabetic, how is your glucose, blood sugar doing, and that. And then medication is either managed by the nurse or the family members, right?
mm,
Where they will give the right medication at the right time. All right. And if there is a problem during the process of stay or during that hospitalization period, then either the nurse will attend it and it will escalate to the doctor if there is a condition that the nurse needs the doctor to be managed, right?
mm,
So think of that journey and put that journey into our digital app. That's exactly
mm,
what we are creating. So when you are back home, what we are doing is every morning there will be a nurse check that will happen. Okay. It will prompt you on your phone that, hey, it is time for your nurse check, right?
mm,
Now, depending on the disease conditions that we have mapped this patient, we monitor the signs and symptoms of that patient with a very, very intuitive way in the app, in your own local language, in yes or no kind of a format. So just like you came out of a cardiac surgery, then the question would be, do you have chest pain? Which is a symptoms to be monitored and reported back if you have a chest. Okay. And then what it does in turn, I'll tell you, is so that's the nurse check part of it. Then the vital monitoring. So the way we do vital monitoring is we have connected devices. All right.
Mm.
So these connected devices are the ones that we give it to the doctor, to the patient. And these are all Bluetooth enabled devices. So they have to basically just, put it on, if it's a blood pressure machine or a SpO2 machine, they put it and we get the data, right? And it's a pretty easy to use interface. And we kind of, as we install this, we teach them, basically we educate them how to do this. And the third is medication alerts, which is, have you taken this medication before breakfast or after breakfast, or have you taken this before lunch or after lunch or in the evening, right? So these are prompts that goes, we collect the data. Most importantly, what happens with the data is that if at any point we see that it is really need attention based on certain trigger points. So it alerts my nursing command center or nurse command center. Okay. And that alert is picked by my nurse command center and acted right then. One, they will triage this. If they think that they will speak to the patient, they triage it. And if they need the help of the provider has a SPOC. They will speak to the SPOC. And then immediately, based on the SPOC's recommendation, the action will be taken.
Yes.
All right. So that's kind of how the journey works here. And that's how we are trying to build a home health kind of a system where we want to enable the patients, the caregiver, the family member. And if you remember when I started about this, where I said 13,000 kilometer apart, can I know what is happening? Now there is a system where I can also log in as a family member and I know that what is happening with the family, the patient, right? So that's more important as well for somebody like, let's say if you're in Delhi, your parents are in Ranchi, right? If they're going through a procedure or something, even a day-to-day monitoring, right? You know what is really happening with them.
Right. And what is the TAT like? Suppose the patient is in emergency and he connected your call center and this nurse connecting him to the provider. How do you make sure that the TAT is like very less?
We have SLAs that we have defined with the provider. What happens is there are different kind of alerts that we monitor. Red alerts. It's just like in an emergency room, right? There is a red, there is an orange, there is a green, right? So that's how we manage it. So the alerts are mapped. So the way we have mapped these alerts are like based on the symptoms when the patient is responding, we map it to what categories is it? Is it a red alert versus an amber alert? Okay. And likewise, we report this. So provider also has a provider portal where they can actually see what is happening with their patient. So they will also get that I have 5 alerts coming from this patient, red alerts coming from this patient.
Yes. And I think it's also beneficial. Miss, I'm just thinking out aloud, like I
Mm-hmm.
may be
Yeah.
wrong as is that insurance companies cover 60 days of post-hospitalization charges as well. So is it beneficial for the insurance companies as well in any ways?
Good that you asked that question. When I spoke about readmission rate, 10% readmission rates within the 30 to 90 days of
Mm,
discharge, right?
mm.
Now, any readmission cost money to the
Yes.
insurance, right?
Mm,
And then any complications or complications that are not attended,
mm,
right, then will cost money to the insurance. In US, what happens is within the 30 days of the
mm.
post-hospitalization, if you get admitted again for the same conditions, insurance doesn't pay for it. So that is exactly where we are actually going and talking to the insurance companies now that, hey, look,
Mm.
during those recovery period of, 60 days, let's look at our product where we can help you
Mm.
to, monitor the patients. Of course, when the patients is in emergency conditions, they have to be back into the emergency room or ICU, whatever, depending on the condition of the patient. But at least really what is happening with the patient real time. Not that you have to act on it, but you don't have data today that X percentage of the
Yes.
population really develops this kind of complication. So
Right.
how do you put that into from a payer's perspective? It is important for them to know that. So far, if you look at the concentration was more on wellness, all right,
Hmm.
or more on the chronic disease. Like I will manage, let's say, diabetes or hypertension, right, or fitness, right, or wellness. What we are trying to stitch is, this is a space where you need to get the data of person or patient that is recovering from a post hospitalization, right? And that is key for the payer, in this case the insurance, to know what percentage of the population develops what kind of symptoms, so that they can work with the provider accordingly.
Yes.
Right. And maybe helps in readmission rates, bringing that down, the readmission rates. In other case, if I look at this, I was doing a study about NHS Scotland. So the way they operate is they have the NHS hospitals, then they have step down care, and then the patient goes back home, right? If we have a similar model, and then I think the transitional care is the process of evolution in India, where there are companies that are trying to establish infrastructure on transitional care, right? If they start looking at our product, where it will help both the hospital and the transitional care is that if the hospital stay is 3 to 5 days, right? And the occupancy is generally the Indian hospital occupancy is anything between 60 to 80%.
Yes.
Right. So what happens there is, if the patient is getting stable, they can move the patient to the transitional care using our app, understanding what is really happening. Patient is doing fine, right? So you can also reduce the number of hospital days. So you have more inflow of the patient, right? Because the patient is waiting. There are patients waiting in queue
Yes.
to get admitted, right?
Yes.
So how this can help the provider as well? That's another way we are looking.
And now I think we have already covered about your ideal customers, in this discussion. And now an interesting question is like around what are the common objections that you face while you are talking to these providers, and how are you kind of tackling those objections?
Yeah, that's a good question, I would say, because that is the real fact, right? As a first mover,
Yes.
people say as a first mover you may have an advantage, but actually it turns out to be a disadvantage for us, because it's a new way, right?
Yes.
Whereas this entire market is flooded with the physical care model, where anybody who is ready to pay a big amount to get a nurse at home 24 cross 7 or as needed, right, they can pay for it and they get the service. But when it comes to technology, people are, and provider in this case, right,
Mm.
um, there is a little bit of hesitance in terms of adoption of technology in this case, all right.
And sorry, Mukesh, just to add on, is that there seems to be conflict as well, like Apollo at the rate home, Max at the rate home. They have created a separate revenue channel and business function within the hospital. With your technology coming in, it's a risk.
I wouldn't actually call that as a risk. I take that as a compliment. I mean, the business complement the technology is how I look at it. So, and I'll tell you my experience with speaking to the head of Max Home when I was visiting India last year. I had a very good discussion with him. And what I learned is that around 15 to 20% of their post-hospitalization patient gets to Max Home, right?
Mm.
They able to provide those services for Max Home. But what is happening for the rest of them,
Yes. Yes.
right? Those 80%, you don't know really what is happening with them, and you don't
Yes.
care about it,
Yes.
right? And it's a large number. We are talking about Max as a group almost doing 17,000 is, I vaguely remember that number 2 years back or 1.5 years back when I was visiting India. It was 17,000 per month,
Mm.
right? Discharges, right? When you put that number into that perspective, you look at that. It's a big number to manage post-hospitalization care for the ones who are not taking Max Home. Of course, Max Home will, if we tomorrow we have this kind of a partnership with Max Home, which I do not at least I don't know if they use any kind of clinical monitoring software.
Yes.
Okay. That will help them. That will complement what they're doing today. What if Rishikesh, uh, want to know what is happening with their parents when Rishikesh parents were admitted in Max, or Rishikesh is taking Max home services. You still want to know that what is really happening with them.
Yes.
That's exactly what where we will complement. Those clinical monitoring is so important. Whether it is done by nurse, firstly, is it recorded anywhere? Is that digitally available some anywhere? Is it giving me the right alerts at the right time? Of course, nurse is visiting, but
Yes.
is the nurse 24/7 versus just visiting for an hour or two or whatever the need of the patient? How about the rest of the time, right? How about the medication adherence of the patient? Like, is he taking medication? Is he missing medication? Is he taking more medication? Right? Who's monitoring that? So that's where we complement instead of I call that as a risk for us.
So we'll come on the objections, like you were talking about some objections which hospitals has.
Yeah. So definitely we see technology as an adoption challenge for sure. Right. Doing, you can open up Amazon app or Netflix app and you can watch a movie. But when it comes to using it for health, we have seen both from patient perspective and from provider perspective, there is a hesitation. That's number one. Number two is from a provider perspective, their hesitation is on their data. And that is because the way other player have, I don't want to name or shame them, but what has happened in past with at least some of these companies have, they have taken data, they have, doing all the sort of things that they should not be doing with the patient data, right? So there are those challenges as well in terms of, are you secured with the data? How do we make sure that you are not sharing our patient data and all those kind of threats that they think about. They also think about data privacy as well as a concern. But I'll tell you what, with my experience, and I have been living this for a decade, at least in healthcare space. No other country has a stricter rule on patient data as in the US. Okay. And I have been in that technology journey out here. So I totally understand how it is to be managed, maintained, right? Whereas if you ask me, the real education of data privacy of patient data is not there in India. Yes.
Yes. Right.
Okay. I don't want to blame this to anyone, but this is a systemic change that has to happen with the policy. So the people that are feared about our data privacy, I can tell you that those are the same people. They must be sharing patient data
Yeah,
left, right,
absolutely.
center.
Absolutely right, sir. Absolutely.
But again, as I said, I don't want to blame them because that's the way India is operating. So there is where the policy change has to be in effect. However, when I come and as the chief technology, person or technology leader in the company, right? My objective is to make sure that my patient data and my provider's data is secure, right?
Yeah.
That's exactly would be my number one priority, right? And that's how we have designed this. That's exactly how the thought process, because coming from US and understanding the system, it is easier for me that what a HIPAA compliance means to me.
Yes.
I go this training every year, same training over and over again. And I know how. I'll give an example here, Rishi, that 2 years back, my like here, what happens is part of your insurance, you have to go through the women have to go through a mammogram after 40 years every year. And let's say if your spouse, even if you are in the same policy, right, insurance policy, you have to be authorized to your spouse data, patient data. So one time I actually went to get a report for my spouse. Okay. That denied me out there that without the consent of my wife, they cannot release the report. Tell me any hospital as large as Apollo, Max, Fortis. Is this something that you would see this in practice, right? So, but I understand this because of the system that I live with. And that's exactly what my thoughts in building this secure system for the provider.
Absolutely, Mukesh. This was a very insightful discussion. We kind of touched upon a lot of very relevant pointers, not only from the product perspective, but also from the perspective of a lot of challenges which are being faced at the provider side and at the patient side as well. Thank you so much for taking out time, Mukesh, and sharing your insights with our audience. I hope that a lot of hospital leaders across the globe will find this discussion useful and will gain something out of it. Thank you so much.
Thank you. Thanks for inviting me on this podcast and wish you luck. Thank you very
Thank
much.
you.